for being here tonight. My name is Alicia Suggs. I am the Vice President of Administration of the Metro New York chapter of the National Black MBA Association. We have such a great series or session tonight in store for you. This is part one of many sessions that we're going to have as it relates to preserving fertility for the driven women. But today it's going to be about dispelling myths and highlighting the facts. Tonight, I'm so excited because we have Dr. Lucky Sekhon here to give you a great presentation on everything related to preserving fertility and family planning, and also to answer any of the questions that you may have. Before we get started, just to let you know, if you have any questions, please enter them into the private chat, and I will make sure that Dr. Lucky Sekhon can address them before the presentation is over this evening. So before we get started, I do want to introduce Dr. Lucky Sekhon. Dr. Lucky Sekhon is a double board certified OBGYN and reproductive endocrinologist and infertility specialist practicing at RMA of New York in New York City. She is passionate about empowering people by educating them about their reproductive health and options for fertility preservation and family building. So with that said, hi, Dr. Sekhon, how are you?
Thank you for having me. I'm really excited to be here. And this is my passion, giving talks like this. And I think a lot of people, even those that might feel that they have at least some information about this, will be shocked to find out some of the things that we're going to talk about today. I think a lot of this was just not covered in our health class and was not the focus. And I think we're thankfully moving towards a place where it's all about educating and really understanding how our bodies work. And I think that is the first step to being the healthiest version of ourselves. So thank you for inviting me here to do this talk.
Thank you so much. So in honor of Women's History Month, women have come a long way as it relates to them being in the corporate arena, and we're seeing a lot more women become leaders and lead organizations. But during that time, there's times when you're so driven and focused on your career that you kind of forget to say or think about family planning until you have that that appointment with your OB and they're like, so are you gonna have kids anytime soon? You're like, well, geez, I never thought about that. And then that's when this whole, should I freeze my eggs or should I not? Even if you're not a single woman, you could maybe be in a relationship, your partner and you may not be ready. So let's take it a step back as because it's Women's History Month. How has fertility preservation process changed over the last 20 years, if at all?
Well, first off, it was invented. The first eggs were really frozen. First eggs and embryos were frozen in the early 80s. This is a very new cutting edge technology in the medical field. So, the fact that it didn't exist before then, I think is like the biggest update. Mm-hmm. And, there are different methods that have been used over the years. And now we use a technology, which I'm going to talk about in my presentation, called vitrification. It's a form of flash freezing. And it's the most successful way to freeze sperm, eggs, or embryos. And this is in contrast to an older technology called slow freezing. So we have better thaw survival rates and better overall clinical pregnancy rates. And it's just a more efficient treatment option now. So, I think that one of the reasons I went into this field, obviously I'm passionate about women's health, but I also just love, specifically in the field of fertility and reproductive medicine, it's so fast paced and there's always changes around the corner.
Thank you. So as you mentioned in your presentation, let's jump into that. Let's talk about fertility preservation as a whole, as well as family planning.
Yeah, I wanted to put up some slides, not because I'm not trying to lecture anyone here or do a biology lesson, but I think that there's just so many abstract concepts that are hard to really picture. And I think it's kind of cool to be able to see some of the things that I'm going to be talking about. Before I jump in, I would love to just talk a little bit about where I work. I assume everyone here is from the New York City area. RMA of New York is the clinic that I work at, and I actually did a lot of my training at as well. So we're part of the Mount Sinai Health System, and we take care of a variety of issues, including fertility preservation, which is the focus of today's conversation. But I do tons of reproductive checkups for women and couples where we're just making sure that the things you can test for are checked out, and a lot of education. Infertility obviously is a huge focus, whether it's of individuals who are using donor sperm or donor eggs, or couples. Patients with irregular cycles or ovulation, fibroids, endometriosis, same-sex couples, people that want to be single parents by choice. So there's, a whole list of things that we handle, and we're huge. We have different locations throughout the city, and I'm physically in Soho and the Midtown East office, but we've been around for 20 years and counting. So now I just want to talk to you, broad overview about what it takes to get pregnant, because I think a lot of people don't even know about these fundamental basics, and this is where it all begins. So I think if you understand this, you're going to understand a lot of the other things that we talk about as it relates to fertility preservation. So human reproduction is extremely inefficient. And I don't mean that to sound negative. I want to be realistic. When you think about what it takes to get pregnant, really, it makes sense to go through the sequence of events, which are, first of all, sperm gets into the reproductive tract, and millions of them will get into the uterus and into the fallopian tubes. And the timing of this is really important. When you watch the movies and people are checking their temperature and saying, okay, my temperature's up. The reason why people fixate on timing is it matters when you're ovulating. Ovulation is the release of a single egg from one side or the other, one ovary or the other. And it's a very random process where, there's no rhyme or reason. You can ovulate from the same side many months in a row, but you're releasing one egg every time. And when that egg is released, it only survives for about 12 to 24 hours. So if it's not met by sperm in that early stage, it's really going to not have a good chance of working and turning into a pregnancy, and it disintegrates. And then you have to wait till the next month when you ovulate. You usually ovulate only one egg every month, or if you're someone who gets a period like every 2 months, you're only ovulating an egg every 2 months, right? So there's this very narrow window of opportunity. We tell patients to have sex in the 2-day window before they are ovulating when they're trying to get pregnant on purpose, because the sperm will survive for much longer than the egg, and it's better to just have it sitting there waiting. That's not the end of the story. That's all you can control. But at the end of the day, not every egg is capable of being fertilized. Not every sperm is capable of fertilizing an egg. And when we try to force this process to happen as part of IVF treatment, normally we say there's like an 80% fertilization rate. So, that's the next barrier. And then will every fertilized egg actually turn into an embryo? And as it turns into an embryo, it grows and, travels through that fallopian tube that you see there back to the uterine cavity, and then finds a nice smooth part of the lining to implant into. So the odds of all these things lining up perfectly are about 15% for the average person. Really, in your 20s, it's like 20% per month or per cycle. And by the time we get into our 40s, it's like a 5% chance per cycle. And the reason it changes as we age is because of the ovaries, right? The ovaries contain all the eggs that we're ever going to have when we're born. And we don't have ability to regenerate eggs or to fix or modify or repair our eggs over time. So both quantity and quality change over time, which we're going to focus on. But when you think about the things to care about, it's helpful to break it into these 4 major components. Can you change it to the next slide for me? So speaking of those components, I just want to go through them all briefly. Sperm is the first one we'll start with because, 40% of couples that have fertility issues, they have some level of sperm quality issues. And it's a really easy thing to test for. It's not an expensive test. We basically get a sample of sperm from the partner, and we will look at it under the microscope and look at things like the count or the concentration of sperm, the percent of the sample that's shaped normally, the percent of the sample that's swimming in a forward direction. All of these things are important, and men are making new sperm every 72 days, so the quality can fluctuate. So we might ask someone to test it on multiple occasions to get a sense of what's going on. Next slide. When you think about the sequence of events, the sperm has to get inside the reproductive tract. So one of the ways to test whether the reproductive tract is open and there's no blockages is to do a test like what's pictured here. This is called an HSG, or a hysterosalpingogram. It's basically an X-ray of your pelvis. You could go to a fertility doctor to get it done, or you could go to a radiology office. And it makes sense to do this if you're actively trying and it's not happening, or if you're in a same-sex couple and you're going to use donor sperm, if you're going to pay for donor sperm and go through that whole, song and dance, it makes sense to make sure that the tubes are even open in the first place. So this involves putting dye into the uterus, seeing if, the dye fills the uterine cavity and forms that triangular shape that you see in the center. That tells you about the silhouette of the uterine cavity and rules out things like fibroids that could be bulging into the cavity, taking up space. It also will fill the fallopian tubes, and you can see those little projections that are like almost like a snake, and then there's like finger-like projections at the end. And if the tubes are normal, they should have a normal caliber, and there should be spillage of dye from either side. If there isn't spillage from one side or the other, that signifies that there's a blockage, and that can happen because of a variety of reasons, like scar tissue formation from endometriosis or prior infections. So this is a great test because it allows us to tell you about two things: the shape of your uterine cavity and your fallopian tubes. Next slide, please.
And Dr.
So,
King, I do have a question. You did mention something about fibroids, and in
yes,
the Black community, a lot of women suffer from that. How
yes.
does that affect, them preserving their eggs at all, if it does?
Yeah, so that's a great question. So fibroids are benign growths that basically are, the uterus is a big muscle. And the muscle cells, sometimes you can just get an overgrowth of a muscle cell, just like you can get a skin tag or any sort of benign tumor. And I want to make that clear. Yes, it's a tumor because a tumor is an uncontrolled overgrowth of a certain cell type, but it's not cancerous, right? This is a benign overgrowth of these muscle cells, and they basically form these big roundish masses. And you can actually see an example of one on the right-hand side in that picture. This is a picture of a saline sonogram where the uterine cavity is filled with fluid, so you can actually see the contour of it. And this is just an ultrasound, not an X-ray. You see that bulge into the cavity? It's taking up space. So fibroids can be located on the inside of the cavity. Those can cause infertility and miscarriages if that's their location. They can also be in the thick muscular wall. And if they're big enough, they can distort the cavity still and make it harder to get pregnant. They can also be on the outer part and, be pushing on the bladder or the bowel or, other parts of the body and make it uncomfortable. And it could be a quality of life issue. They can cause heavy periods, but they don't really interfere with the ability to do the process of egg freezing, which we're going to talk about in great detail. One of the major components of it is being able to extract eggs from the ovaries, and this is done vaginally. So if your vaginal canal is here and your uterus is like above it, right? The way it can affect your ability to go through the process is sometimes if there's fibroids that are low down, they can make it harder to monitor and observe how your follicles in your ovaries or your eggs in your ovaries are maturing and growing. And that's the first step to be able to freeze your eggs. You have to mature as many eggs as possible. And I need to be able to monitor your progress. And if there's huge fibroids, sometimes it makes it hard to see the ovaries clearly. Also, depending on the position of them, most of the time it's not a problem, but if they're big enough, sometimes it can make it hard to even access the ovaries vaginally. And that can make it really difficult to do this well. And in certain instances, I might tell patients with large fibroids, you're better off getting them removed, especially if they're causing other types of issues for you, because, it might make it easier for me to monitor you and to extract the eggs efficiently.
Thank you. That's really helpful.
So going back to this, I wanted to talk to you about the uterine cavity. The uterine cavity is where an embryo implants. So you want to make sure that there's a nice smooth lining and that you don't have a big fibroid bulging into the cavity, because that's essentially acting like an IUD. An IUD is a form of contraception, and it works by, being this T-shaped object that sits at the top of the uterus and takes up space. So you don't want something taking up space and taking away from the surface area that an embryo has to implant. So, if you see something like this, don't despair. There are easy ways to remove them and procedures that can be done that take, half an hour to an hour tops, and there's very minimal downtime. So, it's important to evaluate this. We're going to go to the next slide. Now I want to focus on the fourth component, which are the ovaries, right? The ovaries contain all the eggs. You normally are born with 2 of them on either side of the uterus. And I care about 3 things when it comes to the eggs. Are you someone that ovulates regularly? If you're trying to get pregnant or one day you want to get pregnant, it's important to be able to ovulate regularly. And if you don't, then there are things that we may need to do treatment wise to make you be able to predict when you're about to ovulate, because being able to know that is important for the timing of your attempt. Something I'm going to be focusing on more today in our talk is egg quantity and egg quality. Egg quantity really refers to how many eggs are available at the surface of the ovaries. And essentially, you know, at any given snapshot in time, we can get an assessment of this by doing an ultrasound. And the ultrasound, I'm not counting, millions of eggs or hundreds of thousands of eggs. You're born with 2 to 3 million eggs. By the time you get into menopause, the average age in this country of menopause is around 50, 51. Most people will have less than 1,000. And that's when your cycles start to space out and your ovulations become less frequent and they stop altogether. And that's by definition menopause, right? So most of us on this call are probably between those two time points in our life. And I can get a general sense, a relative sense of where you're at by doing an ultrasound. And when I do the ultrasound, I look to count how many eggs I see, because those aren't all the eggs that you have, but they're a limited subset that have been randomly recruited or pulled to the surface of the ovary. And that's important because it's almost like a rationing. The more eggs you have stored up inside your ovaries at that given time point in your life, the more you pull to the surface. And your brain, your pituitary gland, actually, which is the master hormone gland in your body, sends signals to your ovary and at random will select one of those eggs, one of those lucky eggs, to be the one that gets to ovulate. It's almost like a lottery, right? And that will be the one that grows over the first half of your menstrual cycle and then eventually ovulates an egg. And if that egg doesn't turn into a pregnancy, all the hormone levels fall and you get a period. All those other eggs that got pulled to the surface, they get thrown out. It's like taking out an entire loaf of bread and making a sandwich and throwing out the entire loaf. It's very wasteful. But it's good that this system exists, because when it comes to doing things like egg freezing, or if you're trying to get pregnant and you have fertility issues and you want to do a more aggressive treatment like IVF, both of those things start the same way. You're taking injections, you're taking medications, which are essentially that hormone signal from your brain, but at a higher level, in an effort to select everything that's at the surface, because that's all we can get to. And it's all going to get thrown out, whether you use it or not. So we try to grow all of them instead of just the one that would normally grow, and then extract them before they can be thrown out. And then we essentially freeze them. And we know that taking whatever eggs we can access in a given cycle out of the ovary and storing them for future use means you're retaining the numbers that we have access to now, and also the quality of the eggs that you have now at this current age. So, we'll talk about egg quantity and quality, but these are the two time sensitive aspects to fertility. Your uterus doesn't age. You could go into menopause and come back and use frozen eggs or frozen embryos or donor egg, and you could get pregnant. Even if you're not producing the hormones to support the pregnancy, we could give you the hormones. Your uterus is just a vessel, and it does not change in its ability to have an embryo implant, which is a fascinating thing that I will bet most people here did not know. And the only thing that really matters timeline wise is your ovaries and the eggs they contain. So let's move on to the next slide and focus on the issue of egg quantity first. Oh, but first, this is an overall very depressing image, so bear with me here. But this is the truth. And, we don't want to sugarcoat it. We have to confront this reality that, from a social standpoint, yes, women's rights have come a long way, and socially we've evolved, and now we are equals. We are killing it in the workforce. We are, we can have it all. You can have it all, but you have to be realistic. And you have to know that evolution from a biological standpoint takes, I don't even know, like hundreds of thousands, maybe millions of years, right? So we haven't caught up. Our bodies and our biology have not caught up to socially what's happening. And there is an age-related decline in fertility. And the average age of first childbearing in this country and most countries around the world has been delayed. Most people are putting off their first child until their 30s because they have other goals and things that they need to do, myself included. So it's just important to know this, that you're most fertile in your 20s. Not a lot changes, but there are subtle changes that happen in our early 30s. But then there's a really sharp drop off in our mid to late 30s and onwards. And I don't say this to depress you or to make people feel defeated. It's just informative. And there are things that you can do to be proactive. Next slide, please. The first thing is, what happens to our egg count? And this is a fascinating thing. This is showing a graph of our egg count over time. You have the peak number of eggs that you're ever going to have when you're 20 weeks as a fetus in your mother's womb. And you lose so many by the time you're born, you have like less than 3 million. That makes absolutely no sense. No one understands why this happens. So there's a massive loss of eggs before you're even born. And then a very gradual loss of eggs in our early life. And, we tend to just lose them. This graph is actually incorrect. The curve should look like this, because as you get into your late 30s, 40s, and onwards, you tend to lose eggs a little bit faster. Now, next slide, please. Your egg count really isn't something that you should think of as a fertility test. Like you can actually look at someone as an individual and do two things to understand where they stand egg count wise. You can look at their ultrasound, and that is an ultrasound image of the ovary, and those black little circles, it looks like a chocolate chip cookie kind of. Those black circles are bubbles of fluid that each have one egg floating inside. Those are the eggs that got recruited. Those are the ones that are basically competing to see which one is going to get to ovulate. By getting that count, it gives me a general sense of how many eggs you have. And most importantly, if you were doing something like egg freezing, I could say, all right, if you're going to do this in the near future, this is kind of your potential of how many we could get to. And it's a rough estimate. It's not going to be exact, but that's one of the ways we can assess your current ovarian reserve. And it doesn't tell me about when you're going to go into menopause, how fast you're losing your eggs. It just tells me about what's happening right now. The other thing is a blood test called anti-Müllerian hormone, or AMH. The higher your level, the more eggs you have. So both of these things are useful because I can tell you about your situation as an individual at this snapshot in time. Does it tell me if you'd have an easier or harder time getting pregnant? No, because every month you only release one egg. So having a high egg count doesn't mean anything. Having a low egg count doesn't mean anything. This is the hardest thing for people to understand. All of us are competitive. We all want to know that we have like the best score, right? But it doesn't really matter. It's all about your egg quality when you think about what it takes to get pregnant. Next slide.
I do have a question about the
Yes.
AMH value. What
Yes.
is the range for it? Because if somebody hears like a number 4, they're like, oh my God, that seems kind of low. What is the typical average range of the AMH value?
So that's a great question. It's like saying, what's the range of BMI? What's the range of, I don't even know. I'm trying to think of another example. But, there's just so much variability. You can have an AMH that's undetectable because you have a severely low ovarian reserve. You could have an AMH of 14. I would just say most people lie within like the 1 to 3 range, right? But it depends on your age. Like if you're 25, a normal AMH is like 2.5 or greater, right? If you're 40, I'd say a normal AMH is like above 1. So the target changes according to your age and your situation.
Got it. That's helpful. Thank you.
Yeah. And it's important to know that because there's a lot of like gimmicky places now that will say, we'll give you a free AMH test because they want you to freeze your eggs or whatever it is. But buyer beware. Like it's important to talk to someone who is a professional who can really give you the context of what your numbers mean. AMH is just a number. That brings me to this next slide. My next major point and PSA for all of you is your AMH does not predict your natural fertility. And I see too many young women with low AMH levels and they're, upset and crying in my office thinking that they're never going to have kids. And I'm like, that's not true. Your ability to get pregnant or your natural fertility, let's say, has to do with the chance of ovulating a healthy normal egg. And anyone can ovulate a healthy normal egg, right? It's less likely as you get older, but we all have normal eggs. We all have abnormal eggs. So I'm going to explain what we mean when we talk about egg quality. Next slide. So this is a graph. It's kind of hard to understand, but I'm going to break it down for you. There is an age-related decline in egg quality. Now, this is a graph that's generated from data in a study from an IVF center, just like RMA of New York. It's actually from a place called RMA of New Jersey. And they're looking at 15,000 embryos that were generated as part of IVF treatment. An embryo is a fertilized egg that's been grown into a 100 to 200 cell structure, and they separate out into two cell types. And there's the placental cells, and then there's the cells that become the baby. You can actually remove some of those cells that become the placenta and send them off for genetic testing. And what we look at when we look at these embryos, when we're testing them for IVF to help patients have the best chance of a successful live birth, we're looking at them to just count how many packages of DNA or chromosomes they have. We all have 46 chromosomes. That's what you need to be healthy, right? There are some people that have 47 because they have 3 copies of chromosome 21. That's Down syndrome. There are very few imbalances that are actually going to allow you to live and, be viable as a person. But that is an example of one of them. But a lot of these errors that can happen when an embryo forms from sperm and egg, either it's missing DNA or has extra DNA, a lot of those embryos are never going to implant. You just don't get pregnant that month, right? Or they'll result in a miscarriage. The number one cause of why people have miscarriages is that usually they ovulated an egg and that egg was fertilized by sperm, and something happened along the way where there was missing DNA or extra DNA. And it doesn't have the proper programs to guide normal growth and development, and eventually stops growing after implantation. So this graph shows, of these 15,000 embryos, the proportion that came back testing as abnormal. And I want you to ignore the left-hand side of the graph. The x-axis of the graph shows the age of the female partner, the age of the eggs that the embryo came from. And I'm saying ignore the age range from 22 to 26, 27, because how many 22-year-olds do you know going through IVF? This is a very small, skewed sample size, and they likely had major issues or something else going on. But the data sets gets very robust at like 27, 28 and greater, and that's where I would really trust the data. You can see the percent of embryos which are aneuploid or abnormal is never, better or lower than 25%. So 20 to 25% of your embryos coming from your 20-something-year-old eggs are going to be abnormal. And that's as good as it gets. That's what we start with as human beings, because by that point, it's already been 2.5 decades, right? So anything you own for that long without being able to repair it is going to break down. And as we age, you see like 35. It's like 30 to 35% of embryos coming from your eggs will be abnormal. At 40, it's like 60 to 70%. And as we approach 44, 45, you start to see numbers like 90%. And this is why it's harder to get pregnant as you get older, because the odds of ovulating an egg that's missing what it needs just increases, right? Our eggs start to break down over time. But even a 44-year-old can get pregnant, because at least 10% of those embryos that were tested did come back normal. It's just not the most likely thing to happen. So that's what egg quality really refers to, is we're talking about the genetics of the egg and the fact that that changes as we age. Next slide.
So I do have a question around that, about the
Sure.
age. Is there a cutoff of being able to freeze your eggs? Like once you hit like 45, you can no longer, nowhere will freeze your eggs for you.
Yeah, I think over 45, I would question any program that would happily freeze your eggs without any sort of caution or counseling. And I think you'd be hard pressed to find a program that would be very unscrupulous, in my opinion, because what are people's success rates coming back to use eggs frozen at 45, right? And we'll talk about why. And I'm not saying that there's a number cutoff, but in general, we really discourage women over the age of 44 from freezing eggs. I would say maybe you should consider trying to make embryos. And even if you don't have a partner, if it's more important to you to be able to freeze something, knowing that that's your genetic material, it would be much smarter and better, I think, to try to create an embryo so that at least you can genetically test it and get that information, and it'll be informative and won't give you false hope. If you freeze 10 eggs at 44, because your egg count is decent, that might give you a lot of false hope. Whereas if you go straight through and try to turn them into embryos, at least you can genetically test the embryo, because there's so many cells and you can take a few away and test. And if you have a normal embryo, great. But if you don't, then it's informative. Maybe you would do another cycle. You would have a discussion with your doctor about whether it makes sense or if you need to pivot to a different approach entirely. But, not everyone is open to that. And I have had some patients who, I've counseled and they still want to do it and they haven't come back to use their eggs yet. And we'll see. But my job as the doctor is to give them a very realistic overview of what they can expect. I think the two most important things that dictate your chance of success when coming back to use frozen eggs, if that's the route you take of fertility preservation, are the number of eggs that you froze and the age you were when you froze your eggs. And that sounds really obvious, but when you crunch the numbers, and I do a lot of clinical research, those are the two most important factors when you control for everything else.
So when someone is planning their career, would you say it's smart to plan their fertility as well alongside that, like parallel, because of the fact that there is like a cutoff where you don't want to freeze your eggs? Because say like you're around in your late 30s and you want to go back to school, maybe your PhD, and that's another 4 years, and you're not ready to, have kids. Would you talk to your patient and say, listen, realistically, if you wait too long, this is not on the table?
Yeah, I would. And it's not to pressure people or make them feel anxious, but I think it's all about being a realist. And just, I think even if people don't make use of the technology or do something about it, I think you always feel better when you're not blindsided and you made an educated decision. It wasn't just something that slipped through your fingers, it's something that you made a decision whether or not you wanted to do it or not. It just allows you to take power back from the situation. And, I think it's all about just making informed decisions.
Thank you.
So this is just going back to my broad overview. What does it take to get pregnant? It takes a lot. Next slide. So, just driving the point home, human reproduction is inefficient. When patients come to me and they're like, I've been trying for 2 months, I'll say to them, look, it might take more than 2 months. We don't expect everyone to get pregnant the first month that they try. There's this concept of attrition from egg to live birth. We don't expect every egg to fertilize, to turn into an embryo, every embryo to be healthy. And even the healthy embryos, not all of them are going to find the right spot to implant. So it takes trial and error. And most people will be pregnant. About 80% of couples will be pregnant after consecutive months of trying up to a year. And that's what this graph shows, is your cumulative probability, which starts to level out. If you haven't gotten pregnant at the end of 11 to 12 months of trying, it's not likely to improve with more time. Now, that's not to say everyone should wait one whole year. I think it's dictated by age, right? It's never wrong to check in on the earlier side. I think if you're over 35, don't wait longer than 6 months. If you're over 40, don't wait longer than 3 months because of the age-related changes in egg quality. You don't have a whole year to waste, and you shouldn't. And it doesn't mean you're going to be pushed or you should be jumping straight into something like IVF, but it makes sense to talk about your options and to do early testing to identify if any of those barriers we talked about, like fibroids or blocked tubes, are in play. Because if they are, that might inform your decision making in one direction or another. Next slide. So, what is the goal of what I do, right? We want to overcome the inefficiency of human reproduction, whether we're talking treatment or preventative measures like trying to freeze eggs or embryos. Next slide. So, I'm focusing on prevention. So, what is egg freezing? Well, first off, who should be freezing their eggs? I think anyone that's in a position where they're like, I want to have at least one child. I'm not ready to do that now. And especially if you're in your mid 30s or later, I think it makes sense to really strongly consider this because of the age related changes that accelerate at that juncture in our lives. Especially if someone's starting in their mid 30s and they want to have multiple children. I think that that's a really compelling thing. And I'll give you a personal anecdote. At 34, 35, I froze because I knew that I wanted to have potentially a big family. And being a professional woman, and knowing that doctors independently have, they say the general population has a 1 in 8 chance of infertility. Doctors have a 1 in 4 risk of infertility. And we don't really know exactly what all the factors are in that. But, I didn't want to take any chances. And I actually didn't need to use what I froze for baby number one, but I have 2 girls now. And I have an 18-month-old that I ended up using what I froze and utilizing the technology and getting pregnant at 38. It was much harder for me to get pregnant at that stage. So I've lived through it as a patient and obviously helped so many women through it professionally. And I just could never see myself regretting that decision. How could I? It gave me a backup plan. and an option where options otherwise might have been more difficult or not existed for me. So I'm so grateful for this technology. Anyone who's going through chemotherapy or radiation or any treatment like surgery that could, in an irreversible way, impact how many eggs they have and the quality of their eggs. So if you're ever thinking of having surgery on your ovaries or you're going through a serious treatment, always think about if this is a priority for you, is this going to affect my fertility? And should I take a pause and do this 2-week process to put my eggs on ice before I embark on this next treatment? And if you know that you have to do IVF because you know that your tubes are blocked, you know you were born without a uterus. There are some people that are born without a uterus. And so the only way they're going to be able to get pregnant is to extract the eggs from their ovaries and create embryos and have someone else carry the pregnancy. If you know that you have to do IVF because your partner has a low sperm count, it is always smart to just do that as soon as possible, because the first part of IVF is the same as egg freezing. It's getting as many eggs as we can access in a single cycle. And that's always going to be a larger number at a younger age than an older age. And a higher proportion of those eggs are going to be normal as embryos at a younger age versus an older age. So if you know you have to go through the process, set yourself up for success. Next slide. So the first step, right, is stimulating the ovaries. The left-hand side picture is an ultrasound image of an ovary in a natural cycle where you're ovulating one egg. See how there's one that's bigger than the rest, that bubble of fluid? On the right-hand side picture is how your ovaries look, or how we want them to look in an egg freezing cycle. You're basically taking injectable medications for 8 to 10 days, starting with day 2 or day 3 of your period. If you're someone who's on birth control, then maybe you don't need the period to mark when you would start this process. Your doctor would guide you through the timing of it all. But basically, we pump up the ovaries to try to get all of them to grow, not just one, which is what happens in a normal cycle on your own. And we bring you in for frequent monitoring visits where we're doing this type of an ultrasound, which is a vaginal ultrasound. And they're quick visits where you're coming in the morning before work. There are 15-minute time slots where you're doing blood work and ultrasound to gauge your response to treatment. And once we see a picture that looks like that picture on the right, our work is done. Like, we've gotten as many of them to grow as possible. It's time to call it and say, take your last injection at a specific time. And in 2 days, we're going to do the egg retrieval. Next slide. So this is just a little bit more detail about the medications. This is a woman injecting herself. And this is the region. You'd pinch an area of fat on the lower abdomen and go very superficially. These are actually very thin, tiny, small needles. The needle that you should be focusing on is the yellow one, not the blue one. The blue one is a long intramuscular needle. You're using the subcutaneous one. So it's kind of like what people use to inject insulin, which people who are diabetic do like 4 times a day. So these are easy to inject. They're short, thin, small caliber needles. Other things to just think about are, we're not just stimulating the eggs, we're also preventing you from ovulating, because that's what your body wants to do. And we're going to prevent that with some of the medication that we're giving you. We might tell you to prepare by taking birth control for a few days to a week beforehand. There's a lot of different things that we can do with the medications, and it's always tailored towards your age, how many eggs you have, and a lot of different things go into that decision. We'll normally start on day 2 or day 3 of your period, or 4 days after stopping birth control, like the NuvaRing or birth control pills. And if you have an IUD, it doesn't matter. You can leave it in place because your IUD is not going to interfere. It's sitting at the top of the uterus. So that's something that you should know off the bat. Next slide. So now going back to the egg retrieval. The egg retrieval is done under light sedation. An anesthesiologist will put you to sleep, and you'll be asleep for about 5 to 10 minutes, because if you look at that first picture, that's your whole reproductive tract, and it's showing you your ovaries. The vaginal ultrasound actually goes against the vaginal wall in the corner, and there's a long thin needle that goes through the vaginal wall while you're sleeping. So you don't feel anything, you don't remember anything. And you can actually see that needle in the next picture, the second picture in the middle. So the top row in the middle, there's a little needle that you see coming down that straight line. That's how we do it under ultrasound guidance. We're basically piercing each bubble and draining them and watching them collapse. It's actually it's like ASMR. Is that what it's called? Yeah, it's very soothing. I love doing my egg retrievals because I just find it Very oddly satisfying to watch. And then you're draining all of the bubbles of fluid, and then you're handing the tubes of fluid off to the embryologist, who is a specialist that sits in the lab next door to the procedure room, and they sort through the fluid and they look at it under the microscope, and they're basically identifying the eggs. And those are pictures of eggs in various stages of development on the bottom. And that's important because not every egg that we get out at the day of the egg retrieval will be mature. And mature means a specific stage of development where that egg is actually capable of being fertilized successfully. And so there's very subtle differences, but these are all 3 stages of immaturity, going from most immature to immature. And you're probably thinking, what the heck? They all look the same to me. But there's little nuances. Like I can tell them from, a mile apart. But we want the one that looks like the lower right hand corner picture. That's a mature egg. Next slide. So you can freeze these as eggs, or you could turn them into embryos and freeze them, right? And these are the 2 different stages or 2 different forms of freezing that we were talking about, that you asked me about earlier. Slow freezing was like the slow programmed cooling, and it caused a lot of ice crystal formation, and that's why we found that success rates weren't as good. That was like in the 80s and early 90s. Now, for many years, we've been doing vitrification, which is a rapid cooling, flash freezing, and the fast cooling minimizes ice crystal formation. So that's the game changer. There might be some clinics in the country, especially like rural areas, that aren't very up to date, that might still be using slow freezing, but not in New York City. Next slide. So what to expect, right? Because a lot of people might be reluctant to think about doing this because they're worried about how they're going to feel. And it's different for different people. Just like AMHs can have such a wide range, so can side effects. But most people will find that this is 2 weeks of your life. It's 8 to 10 days of shots, and 2 days after the last shot, the actual retrieval. And then after that, you're not doing anything. You're done. You're just waiting for all of the hormones to get out of your system. And normally that happens a week to 2 weeks later, and that's when you get your period. So, side effects, most people will complain about bloating, feeling like a fullness in their pelvis, maybe some superficial bruising around the needle injection sites, but those look scary, but they don't feel like anything. They're not usually very sore. Less commonly, some patients will complain of headache, feeling tired. Some patients will have mood symptoms, but that is the number one thing that everyone worries about. They think they're going to go crazy and quit their job and like bite their boyfriend's head off. And I'm like, no, this isn't like having PMS. That's a different mechanism. You might feel more mood symptoms than usual, like the week before your period after this process, because your hormone levels are dropping. That drop in progesterone is what causes mood symptoms. But most people don't have mood swings when they're actually on these injections because their levels are going to be high, not dropping. We tell you no high impact exercise and no sex, because you can see the ovaries sit right next to the vaginal canal. So sex is high impact to the ovaries because they're big and you don't want to twist them on themselves. So that restriction lasts for a week leading up to the egg retrieval and at least a week afterwards. And then, I think it's important to have expectations about what kind of results you could expect to see if you ever came back to use your frozen eggs. So that's what I want to talk about next. Next slide. Sorry. So this is an inverted pyramid to illustrate the inefficiency. All of the things that I told you happen when you're trying to get pregnant, the inefficiency, the drop off, that still happens. Just because you froze your eggs doesn't mean that magically goes away as a problem. But the game changer is you're not just starting with one frozen egg. Ideally, you're going to have multiple eggs so you can afford to lose along the way from the moment you go to thaw them, fertilize them with sperm, grow them into embryos, genetically test the embryos, and then actually transfer them into the uterus. Next slide. Now, as I mentioned, the 2 most important factors that will influence your chance of success is the number of mature eggs that you start with and how old you were when you froze your eggs. And I guess the letters got jumbled for some reason in the formatting, but that's pointing to the proportion of how many embryos would be genetically normal. That's going to be directly affected by your age that you were when you froze your eggs. Next slide. So before I talk about the drop off that you can expect in typical numbers, remember, just having frozen your eggs doesn't mean that you have to do this to get pregnant. Try on your own. And if you're not pregnant after a certain amount of time, and maybe you'll base that time frame on your sense of urgency, your life situation, and how old you are, how much time you have, then you'll come and talk to us and we might say, oh, you know what? Given your testing or your partner's testing, you need to do IVF. Oh, great. You froze eggs when you were younger. So you're basically setting yourself up for success with IVF should you ever need it for whatever reason. If you choose to do IVF and you have eggs from when you were younger, you're going to be starting out with a larger cohort and a higher proportion of those eggs will be healthy. So you're just setting yourself up for success and making sure that your treatment would be easier and more successful than maybe what it would be at an older age. So the first step is to thaw the eggs. Our average thaw survival rate is about 85%. But when women freeze their eggs in their 20s and early 30s, it's closer to 90 to 95%. So there is an advantage to doing this younger. And it depends on the technology used. Better thaw survival rate with vitrification, your age, your egg quality. I think quality of the lab is important too. You want to go to a place that does a lot of IVF, places that do a lot of anything, whether it be surgeries or certain procedures. They're going to be good. They're like well-oiled machines and their labs know what they're doing and they have personnel that are like top notch. So not to sound snobby, but location matters, and I think going to like smaller boutique practices that don't have high case volume, it's hard to know exactly what you're getting. So I think it is important to think about where you're doing this and making sure the place is vetted. And I think having people that that have had good experiences at certain places, that can also be a good clue because you don't always know what's happening in the lab. Next slide.
I do have a question, Dr. Seekon.
Sure.
So when you're about to talk about fertilization, but when you have your frozen eggs, is it true that you put 2 eggs in at the same time to fertilize? Or
so we would thaw out everything or a certain number. Like if you had a lot of frozen eggs, you might say, and this is where the strategy comes into play. Like I had a couple the other day that was like, she froze, like 24 eggs at age 34 and now is back at 37 with her partner who she didn't have before and was like, I would like to thaw out 12 of my eggs because I'd like to keep 12, like the other half for myself. And he kind of looked at her like, what? And she said, because who knows what's going to happen with our relationship, And these are types of decisions that can be made. But if she had frozen only 12 eggs, I would not maybe tell her to only thaw out 6 because maybe that's not going to give her enough to ensure she'll end up with enough embryos. So these are all really important strategy type decisions. When you go to fertilize eggs, you can inject sperm directly into each egg, or you can dump 50,000 sperm onto each egg directly. There's different ways to do it. But in general, about 70 to 80% of eggs will fertilize successfully. That tends to be our average success rate with fertilization. So there's drop off there, not so much, but some drop off. Next slide. Then we grow them for 3 days into a day 3 embryo, which is highlighted on the left there. It has like 8 to 10 cells and it's grown and divided. And then by day 5 to day 7 post-fertilization, they should look like that on the right, where they've separated out into 2 cell types. That cluster on the side of that clump, that's what becomes the baby. And the ones that line the periphery, those are the ones that become the placenta. So and only 60% make it to the day 5 stage. That is normal. This is all part of being human. It takes a lot for an embryo to get to that stage of development. So this is something you bake into the equation of how many eggs you need to feel confident. Next slide. This is just showing what it would look like to remove some of those placental cells and use a laser. That's what that red dot is, to just trim off some of those placental cells and send them off for early genetic testing to count how many chromosomes or packages of DNA are in each embryo. It's pretty fascinating. Next slide. You can test for many things. This is just basically showing you that you can test for the number of chromosomes. You can test for things like cystic fibrosis or other disorders. So if you know that you and your partner both carry sickle cell trait, you could have a child with sickle cell anemia. These are things you can test embryos for, but you'd have to know what you're at risk of. So there could be genetic testing that you and your partner do in advance to understand what your risks are. If you know that one of you carries a cancer-causing mutation, like the BRCA gene, you can actually test the embryos for that to avoid passing that on to future children. You can select a male or female embryo. That's not a problem. And then HLA matching is something where you're just trying to select a sibling that matches the immune profile of an existing child. That's hardly ever done. So we're going to move on to the next slide. So this is going back to the original thing that I showed you about the proportion of embryos that are missing or have extra DNA. And this is where that data comes from, being able to do that biopsy and send it off for testing. Next slide. So next stage in all of this, the culmination of all of this, is a transfer of an embryo. And this is actually a really easy process. You fill your bladder. That's what that black bubble is on the ultrasound. That's a side profile view of the uterus. And that white thing that looks like it's coming up this way in the right-hand side ultrasound image is the actual catheter. And you can see a cartoon of it. There's a catheter that's flexible and it has a syringe attached to it. And that's what we use to push with the plunger the embryo to the top of the uterus. And that's all we do. We just drop it off at the top of the uterus and hope for the best. 8 to 9 days later, we do a pregnancy test. And honestly, our success rates are extremely high, especially when you know that it's a genetically healthy, normal embryo. I see success rates of like 80% week after week. Our overall practice success rates, because some women have fibroids in the uterus that are hard to correct or other issues. So we say normally like 60 to 70% chance of live birth. But honestly, I think when you control for all these other factors, it's really, really easy to get pregnant once you get to the point of having a genetically tested embryo. Next slide. So going back to this, 85% survive the thaw. Of those, 70 to 80% fertilize. Of those, 2/3 grow into embryos. Of those, X%, depending on your age of the eggs that were used, will be normal or abnormal as embryos, and then about 2/3 chance of implanting. Next slide. So, there's calculators online, take them with a grain of salt. Brigham and Women's Hospital, that's what BWH stands for, has this tool. You can play around with it. You put your age in, you put the number of mature eggs frozen, and it'll give you what's in the green at the bottom, the probability of 1 live birth, probability of having 2 kids from those eggs, and probability of having 3 live births. I think these numbers are a little bit skewed towards being more pessimistic because it's based on this clinic's data and it's a small center in Boston, right? But I honestly think you could go by these numbers, which is from my clinical experience. If you're going to a good center with a great quality lab, if you're 20 to age 30, if you have 6 to 8 eggs frozen at a minimum, that's good for 1 live birth. If you're 30 to 35, 10 to 15 at a minimum. If you're 35 to 40, maybe 15 to 20 at a minimum, right? So the older you are, the more eggs you need to make up for the attrition that we expect. And if you're freezing embryos, it's a simpler calculus because you can test the embryos. If you have 2 to 3 normal embryos, that's great for 1 live birth, right? With the statistic of 60 to 70% resulting in a live birth. And if you didn't genetically test the embryos, well, then it depends on how old you were when you created them. And then you would go based off of that chart that I showed you. Does that all make sense?
It does. Thank you.
Next slide. So eggs versus embryo freezing. I know this picture's terrible. I need to get a new picture. The pros of eggs are flexibility. It involves you. There's no legality to it. You're not worried about putting all your eggs in one basket. Sorry, I had to make that joke. The pros of embryos, though, are that you can actually figure out what you have because you're getting towards the bottom of the pyramid. You already know what happened. There's no mystery about, what lies ahead. And the thaw survival rate is better. Embryos will survive the thaw like 98% of the time. It's very rare to have an embryo not survive. So there are medical advantages to embryos, but using an embryo is only possible if that person allows you to, right? Because now there's 2 people involved, unless you're using a sperm donor, in which case they relinquish all rights. So that's a different situation. Now, the chance of your success, as I mentioned, does not depend on when you come back to use the eggs or embryos. Your age of your uterus does not matter. We have patients that use donor egg and they're 50, believe it or not. Obviously, they have to be healthy and, optimized for pregnancy, but they get pregnant really well. And, how long the embryos or eggs are frozen have no bearing on their reproductive potential. So that's good to know. And it doesn't matter if your ovaries work or not. If you freeze something and you go into menopause early, which is something you can't predict, you can come back and still get pregnant, which is awesome. Next slide. So special consideration, if you're in a partnership and you want to freeze something, do you freeze eggs or embryos? That's such a personal decision, but talk to your doctor about it. What do you want to look for in a clinic? Well, look at IVF success rates, even if you're just freezing eggs, because you want to be confident that you're going somewhere that does IVF well, does a lot of it, and has high success rates. Because the most important thing is being able to come back and use your eggs and to feel confident in the lab's ability to thaw them out. I think centers that both freeze and thaw the eggs out and do IVF because there are some pop-ups that just freeze eggs, but be wary of that because we don't accept eggs from places like that. We don't know what the quality is, right? So you want to make sure you can actually use these eggs. And I think going to a long-standing, stable clinic that has a good safety track record, places like where this is the reason why I work where I do. I don't own a stake in my company. I'm not a founding partner or anything. I'm an employee physician, but I can't sleep at night if I'm not confident that the trust that patients are putting in me, is not going to be honored. And I know that there's stringent processes in place where the temperature variations are tracked. Everything is taken care of. It's such a immaculate, meticulous process. And, I can at least know that I don't have to worry about that. And, my patients are in the best hands, even when it comes to the lab. It's always better to thaw where you froze because I think there's always slight variations in the way things are done, especially when it comes to eggs. That's important. So if you, freeze your eggs and move away, that's not a big deal because it doesn't take a lot to come back and use your eggs, and you could do all the prep for it that's required in another city. And then you could just fly and have your transfer done, and that would be totally fine. That takes a day and there's no anesthesia. You can't test for and anticipate everything. When you do a cycle, that provides a lot of valuable data. And if you ever have to do another cycle, you choose that you want to freeze more eggs, let's say, or you want to make more embryos. We can go based off of how your body responded in prior stimulation cycles to improve the outcome of future cycles. So nothing's ever a waste. And never be afraid to get a second opinion and advocate for yourself. That's really an important message. Next slide. So with that, I'm going to leave some time for questions. I also want to let you guys know where you can find me. Obviously, I work at RMA of New York. You can make an appointment online or call. I'm really active on social media, which is something that's newer for me, but it really stemmed from the pandemic and feeling frustrated with all the mixed messaging about vaccines, especially with women who are trying to conceive or pregnant. And it just kind of took off from there. And I've realized there's so much misinformation, and those voices tend to be the loudest. So as a physician, even though initially I felt it was cringy and maybe not professional, I've really kind of opened up to the idea and embraced it. So you can find me on Instagram. I try to do a lot of education there, and it's all for free, not for any gain of any sort. And I also have a personal blog called theluckyegg.com. And I just put a lot of frequently asked questions and answers on there that could hopefully reach a broader audience. And then you can also email me directly if you have any questions you don't want to ask here, if you want to set up an appointment.
Thank you so much, Dr. Seacon. That was amazing. I even learned a few things too.
Awesome.
We do have two questions, and you probably already answered them, but I'll ask again. What do you do when you've, you're over 40? Is there anything left to preserve?
Yeah, I think it depends how over 40, but I think, it makes sense to come in and get an assessment, look to see, because I've had patients at 43 that have an extraordinarily high count, either because they were born with more eggs than the average person, and it's just like a genetic thing, or they lost their eggs at a slower rate than their similarly aged counterparts. And if you have a really high egg count, it might be worth freezing eggs because maybe you'll feel like, hey, the count is high enough that I could overcome some of the age related attrition and quality issues that we anticipate. Maybe, your life situation involves a partner, and that will inform your decision of whether you want to talk to them and think about doing something like embryo freezing or using a sperm donor to create embryos. So you can at least do that genetic testing and know about the quality up front. And if that's not an option, donor egg is a really great tool. And a lot of people, when they first hear about it, are like, no, no, no. But I think it's worth a conversation I think everyone owes it to themselves to really understand what their options are. And I don't think that you can answer it in a blanket statement. I think it has to be an individualized assessment. Sure, there's no way for me to test one's egg quality directly, but there are nuances to things like your egg quantity and what your goals are and the options that you would be open to.
Thank you. And then the second question is, what's the optimal age to freeze?
The younger, the better. The younger you are, the more you're going to get, because we know that you don't make more eggs over time. You don't fix your eggs over time. So if you're in a position where you're like, I'm 100% going to freeze my eggs, it's just a matter of time, then do it now. If you're like, I would like to only freeze my eggs only if I have to, which is what most people say, well, then I would say it depends on how many kids you want. If you only want to maybe have one kid and it doesn't matter to you to have a big family, as you start approaching like 35, I would think seriously about it if you're not in a life circumstance where you would consider in the next year or two starting to try, right? And obviously things can change and move very quickly, but most people, if they're single and they want to go like the traditional route of meeting someone, dating, getting married, having a child, like it takes time to go through all those stages. So I think if you're approaching your mid 30s, it's never a bad idea to just consider freezing if you're not in a position where you're like, I would start trying anytime soon. Not to say everyone has to do that, but I think if it's important for you and it's a source of anxiety, then it's going to make you feel better that you've done something about it.
Thank you. And I know we're almost at the top, well, at the top of the hour. We have like 3 more questions. Is that okay?
Of course.
Okay, great. So this is a question about insurance. I know you probably don't know all of this. I know we're going to have a different additional series as it relates to fertility preservation. So those on the line, just, hold tight. We have more sessions coming. But any information that you can give on cost of this procedure overall will be helpful.
Yeah, of course. So I'm seeing a lot more coverage, which is so great because I feel like 5 years ago, I couldn't have said that. I'm noticing there's a huge trend, and this is great for this audience because I'm sure a lot of you, work for companies that, or will work for companies that are probably offering it as a benefit. I just am seeing it a lot in the banking world. I'm seeing a lot in the tech space. I think they were the pioneers, obviously like Google and Facebook, but even like Starbucks, like you don't even have to be in a corporate role. Like there's a lot of big corporations now that it's like they're jumping on the bandwagon and who cares what their intentions are? Like we benefit from it, right? And I don't even think it should be viewed as a perk. I think it's a right. And I think if people want to continue to have a diverse work environment and to promote an environment that is welcoming to women and people that are interested in building families, I think it's important for them to offer these benefits. And if you don't have a benefit, I would strongly recommend that you go to HR and you lobby for it. And I've had patients even ask me to speak, with their HR, and I'm happy to do that. These are the things that are like passion projects of mine. And I think it's really important. We have to advocate for ourselves as women. And sometimes your HR isn't thinking about it because no one's brought it up to them, but it's such an important thing and it helps your company to be more competitive. So that's, one issue. I think coverage is going to continue to expand and it's catching on like wildfire and it's great. And I love when patients can benefit from that. It takes a lot of the pressure off and it makes the decisions more medical, not about what's feasible,
Mhm.
in and of itself, without insurance coverage, egg freezing is expensive. It's like $9,000 out of pocket. And that doesn't always include medications, right? So you're looking at maybe like ten to $12,000. Usually places will say like storage is covered for the first year, but then after that, there's also a storage fee. It might be like $500 every 6 months. Um, so, it's not cheap. There are places that might freeze your eggs for like $5,000, but question that and wonder about like if there's corners being cut or what the gimmick is. Like, are they also doing IVF or is their shtick just to do egg freezing and not really worry about when you come back to use your eggs? So it's hard because these are businesses too, and it's hard to know who to trust. So I think it is important, to feel that you have a trustworthy, open communication doctor-patient relationship. And I think no two clinics are equal, no two doctors are equal, and that's where getting a second opinion and making sure that you feel confident that the clinic you're at is transparent about their pricing. Like you should be able to speak to a finance coordinator or someone that's there and dedicated to just hold your hand and help you navigate that aspect of the process because it's overwhelming and it's high stakes. It's a lot of money if you don't have coverage. If you're doing embryo freezing, it's about double that. I would say it's like $15,000 to $20,000, especially if you're doing the genetic testing of the embryos. Some of this is not within our control because we're sending those samples off to an outside lab and it's a very high tech methodology and a lot of really expensive equipment is used in the process. So This is not cheap, and this is, you know, something that should be universally available, and especially to those of us, all of us who have worked so hard, and because of that hard work to get to where we are right now, oftentimes it means delaying our personal goals. And I think that it's only right that it's covered and that we're supported in that.
Thank you. Question: does embryo freezing generally produce more than one child?
Like twins? No, because you can control putting back one embryo at a time. IVF gets a bad rap. A lot of people will say, "Oh, I don't want to do IVF because that's more aggressive," and more aggressive means like things like quadruplets. And yes, it's true. Like back in the 70s and 80s when IVF was first invented, it sucked. The success rates were so low, and it was still expensive back then. And we didn't know how to freeze embryos. We didn't know how to genetically test embryos. So what we would do is, and I'm saying we, but I was literally probably in elementary school, like, or not born at that time. But, you know, the forefathers of my field, like my mentors, some of them, you know, who are still in practice, tell me about these things. They used to put back multiple embryos because it was kind of like, well, whatever we create in the lab, let's use it because we don't know how to freeze them well, you know, and we just didn't have the technology. Now we can freeze so well that 98% of embryos survive the thaw. So there's no downside. We freeze all the embryos and we just put back one at a time in a controlled fashion. And because the success rates are so high, there's no need to put back more than one. So can an embryo split? Yeah, that happens like 2% of the time. Very low chance of that happening. But because the majority, I'd say like more than 95% of embryo transfers that we do at RMA involve the transfer of one healthy embryo one at a time, our twin rates are extremely low.
Okay, we're going to take one more question and then we're going to wrap. If you froze at 37, at 43, should you go straight to IVF or try naturally for a while?
I would try naturally if you want to, you know, especially if you have some eggs or embryos frozen from when you were 37 and you want to have more than one and you're just starting out. Wouldn't it be lovely if you could get pregnant with baby number one and then save what you have for the second child? Because it's just going to be harder, you know, at 44 or 45. But if you're like, I just want to have one, I mean, there's nothing wrong with trying on your own. Obviously, the older you are, the higher the risk of things like miscarriage, because when you ovulate an egg, there's no testing of the egg, like you're taking chances. But, you know, that would be a conversation worth having early on. And I wouldn't say try for a while. I wouldn't say try for a year. I would say like maybe you'll try for 2 or 3 months. And if it's not working, you'll come in and talk about it and seriously consider using what you froze. You'll have a much better chance using what you froze at 37 than trying on your own at 43.
Great. Thank you so much. But again, Dr. Seacom, thank you so much for being here this evening. I know we had some more questions, but we'll take them and ask them all offline and get back to you all. Again, this is part one of several series that we're going to have as it relates to fertility preservation. So please look out for the announcements as they come out. Dr. Seacom from RMA of New York, thank you again for being here this evening. This was such a great informative discussion. I learned a lot, like I said, and I'm sure everybody on the line did as well this evening. And on behalf of the Metro New York chapter of the National Black MBA Association, my name is Alicia Suggs, and I'm the Vice President of Administration. Thank you all for being here and have a great rest of your evening.